She is Associate Professor, Department of Critical Care Medicine, St. John's Medical College, Bangalore. And today she'll be talking about approach to patient of hypoxia. And it is very important for all of us to identify such patients because we encounter these kind of patients very frequently in ICU, especially for the nursing staff. And primarily, nursing staff should give the primary treatment to such patients because persistent hypoxia can cause deleterious effects, especially immediate effect on the brain and cardiovascular system. Until and unless they call a senior resident or a senior doctor, so they should be the first one to attend such patients. So I hand over to Dr. Carol now. She can start her presentation. And any questions we'll take up at the end of the presentation, or you can just write it on chat. Thank you. Over to you, Dr. Carol.
Good afternoon, everybody, and thank you, Dr. Mahima, for that introduction. And also thanks to ISCCM for giving me this opportunity to introduce this important topic to our nurses. I have made it entirely for the nurses and not trying to introduce very difficult concepts. So this is, like Dr. Mahima pointed out, a very important topic because hypoxia is a frequent emergency that you all encounter as critical care nurses. And one thing that I want to highlight just to begin with is that as nurses, whenever you see a hypoxic patient, I know the first thing is most of you all get alarmed and go run to call your senior or run to find your doctor. But at the end of this talk, my aim is to sort of like give you some sort of a clue as to how to go about at least the first few steps, how you can pick up and try to sort of troubleshoot the problem by yourself itself. So the definition, so now commonly you would have seen that hypoxemia and hypoxia, these are two terms that are interchangeably used. So I just wanted to tell you the exact definition. When you say hypoxemia, when you say emia, it means something in the blood. So hypoxemia technically is defined as a low level of oxygen in the blood. That is, your partial pressure of oxygen in the blood is less. When you talk of hypoxia, now hypoxia is a general condition and it will explain something that's happening at an organ level or a tissue level. So when you say hypoxia, hypoxia is basically a condition where the oxygen supply to your body is inadequate, either the whole body or a specific region. So that's general hypoxia or regional hypoxia. So hypoxemia is one of the causes of hypoxia, but even if the oxygen pressure is normal, the tissues can be hypoxic. And where are these conditions? We will elaborate in further slides. So why are we having this talk? Why is hypoxia such an important hypoxia or hypoxemia such an important concept? So basically, oxygen is the main fuel that drives your body. So hypoxia is the condition where the body tissues receive inadequate oxygen. If there is a decrease in the oxygen, this automatically will release or lead to a disruption in your cellular function. There will be a switch to the anaerobic metabolism, and this will not be sustained by your body. There will be subsequent lactic acidosis, and if not treated, it can go on further to cell death. What is very important to note is that some organs are more susceptible, especially the brain. The brain does not tolerate a long period of hypoxia, which is why during airway manipulations or intubations, they are very, very important to maintain, or we take a lot of care to maintain the normal saturation level because we don't want to cause any hypoxic brain injury. So before I go on to this talk, I'm just going to leave you here with one question, which I want all of you all to sort of ponder about. Okay, so there are two patients I'm showing you. One patient has a room air saturation of 92%. This is patient number A. And the second one is patient number B, who has a saturation of 96%, but this he's maintaining with 10 liters of oxygen on face mask. So at this point of time, just ponder and think which patient you are more worried about. We will discuss on this a little while later. So hypoxia, as already pointed out, it's a frequent occurrence in critically ill patients. And more often than not, depending on the severity of the hypoxia, it is a medical emergency. So whatever you take away from this talk, I want you to take away these two steps, that whenever you see a desaturation or a hypoxic patient, first things first, like I showed you the first slide, no panicking. Do not panic, because with good troubleshooting and good help, you should be able to sort out the problem. Of course, you should not hesitate to call for help. This could be your senior nurse, a co-nurse, or the doctor. Now, very important to remember is that oxygen, just like any other medicine or drug that you give, oxygen is also considered as a drug nowadays. And oxygen therapy, ideally, you would always take any drug orders from your doctors. But in this case, if it's an emergency situation, you can initiate this without a physician's order in an emergency situation because this is a life-saving treatment. So do not hesitate to start oxygen. The first thing you should do is don't panic, call for help, And the third thing is start oxygen. Whatever device you have around you that can provide the highest oxygen, at that point in time, introduce it and then try to troubleshoot the cause. So before we go into what are the causes or how do I approach a patient, first of all, you should understand how does oxygen enter our body and what happens to it once it enters our body. Because basis that only you will be able to identify the probable pathophysiology that's going on in your patient. Okay, so all of us, I know you, I'm sure you all know that we all breathe in oxygen from the air. So in the normal atmosphere, our FiO2 is 0.1 or 21%. If the patient is on an oxygen delivery device or the mechanical ventilator, that depends on how much oxygen flow is going from that particular device. Now, once you inhale this, the oxygen passes through your upper airways, your nose, nasopharynx, into the upper airways, that is your trachea. And then through the bronchial tree, it enters the lungs. Now, in the lungs, in the alveolar space, what you see over here is that the oxygen will diffuse from the alveoli into the capillaries that are surrounding the alveoli, and the oxygen will enter the RBCs. Here, within the RBCs, what happens is it binds to this important molecule called hemoglobin. 4 molecules of oxygen can combine to 1 molecule of hemoglobin by cooperative binding. And this hemoglobin is the main carrier of oxygen. And of course, you need a normal cardiac output because the blood flow is what is going to take this oxygen with the hemoglobin to all the tissues of the body. So one important concept I want to tell you is that the oxygen delivered in your body is delivered in 2 forms. One is the oxygen bound to hemoglobin, which is I've shown you over here, which is bound to hemoglobin. And another part is oxygen that is normally dissolved in your plasma. Okay, so an important concept you should remember is that majority of your oxygen, when I say majority, I'm talking 97 to 98% of oxygen is usually bound to hemoglobin. So this is the main carrier of oxygen in your body. So why this is important is that, and only less than 3% is in the dissolved form. Why this is important is that if your hemoglobin is low to begin with, you can increase your FiO2 or you can increase the oxygen, but until and unless you correct the cause or correct the hemoglobin level, then the oxygen carrying capacity of the blood is not going to improve. This is called as an anemic hypoxia. So this is an important concept to remember, that majority of the oxygen is transported by hemoglobin. Now the same slide, let's go at each and every stage and see what could go wrong that can cause hypoxia in your patient. First thing first is the step starts with FiO2. That means at the fraction of oxygen you breathe from the atmosphere. If that itself is low, that will be the primary cause of hypoxia. This could be either that you are administering less or the patient is, this also can be seen at higher altitudes, because at higher altitudes, the barometric pressure is less and the amount of oxygen in the atmosphere per se is less. But in a clinical setting, it's more often than not that you are not giving an appropriate amount of oxygen to the patient or fraction of inspired oxygen. So this is very simple to tackle. You just have to increase your FiO2. Hypoventilation. Why would your patient hypoventilate? A very common cause you see in your ICU is because of the administration of CNS depressants like opioids, sedatives, but other causes could also be there. Neuromuscular diseases, CNS diseases, because CNS is where the respiratory centers are. So for any reason, if your patient is hypoventilating, one of 2 things will happen. The FiO2 or the oxygen the patient is breathing is less. And also because the patient is hypoventilating, they're not washing out carbon dioxide. So you will get both hypoxia as well as hypercarbia in these patients. Next, coming to the upper airway. So the oxygen has to pass through the upper airway to enter the lungs. If there is any upper airway pathology, be it a foreign body, be it smoke inhalation injury, an obstruction, angioedema, so on and so forth, that will obviously hamper the patient's breathing and therefore be a cause of hypoxemia. Coming now to the lungs per se, to the alveoli, if I would be more specific. If you go to the alveoli, the normal alveoli have a very thin lining of surfactant and its main content is usually the air. But if anything else is present in the alveoli, like fluid, example pulmonary edema, infected tissues or infected material, fibrinous material, like in pneumonia or ARDS, blood, like in the case of alveolar hemorrhage, or that alveoli is completely collapsed, so there's no oxygen that can enter this alveoli, like in atelectasis. All of these are also potential and important causes of hypoxemia, which without treating the cause is not going to improve. Next thing, what did I say? The blood has to diffuse across the alveoli into the capillaries through something what you call as a alveolo-capillary membrane, which is right here. So if the blood is not able to diffuse through this could happen because of a diffusion defects. If there is a pathology that is there with this alveolo-capillary membrane, one common example would be interstitial lung disease. So how much ever oxygen you give, the diffusion will be limited. So even if the alveolar oxygen is normal, the amount that is going and diffusing into the bloodstream might be less, and this diffusion defect will be a cause of hypoxemia. Another important thing is, of course, anemia, because I told you maximum amount of oxygen is bound to the hemoglobin. So if the hemoglobin is low, or it's an abnormal form of hemoglobin, which does not bind to oxygen as compared to the normal hemoglobin, then that also can give rise to a hypoxemic condition. A common example for abnormal hemoglobins is methemoglobinemia, carboxyhemoglobinemia. These are a little difficult to detect. You have to see it in the clinical setting in which it could occur. And more often than not, of course, this hemoglobin, like I said, it has to go along with the blood via the normal cardiac output. So if the cardiac output due to any cause, especially a cardiogenic cause, is already low, the patient is hypotensive, there's a circulatory failure, this itself, even if the lungs are normal, even up to this point if oxygen is there, if the cardiac output itself is low, then the patient can also develop a hypoxemia. So the importance of this slide is that you have to figure out at what point your patient lies over here. It's the simplest and easiest thing to do is obviously to increase the FiO2. But if you don't tackle the cardiac output, if you don't increase the cardiac output, if you don't tackle the disease process that is here, you don't tackle the obstruction that is here, no matter how much of oxygen you give, the increase in the PaO2 levels will be very marginal. I want to introduce you to another concept which you may have studied in your physiology when you all were nurses, but it's an important concept to understand hypoxemia. So now I told you about, the alveoli and the capillaries passing the alveolar capillary membrane. So there is this principle of ventilation and perfusion. Ventilation is what? The air or the oxygen that is entering your alveoli. That is your ventilation. Now, if the oxygen has to diffuse into the blood, there should be a normal perfusion. So that means there has to be a normal ventilation as well as perfusion for normal oxygen or gas exchange to happen. If one of these two is impaired, then that can be a severe cause of hypoxemia. So one of the important factors that can be affected is your ventilation, okay? So if your perfusion is normal, but ventilation is hampered, see over here, you can see over here, there's a block over here. So there's no oxygen that is entering this alveolus. So there's absence of ventilation, but perfusion is normal. So this is called what you call as a shunt. Okay, so there is a shunting of oxygen. So what you're seeing is that the blood is not getting oxygenated in the lungs. It's the same deoxygenated blood that is just moving around in the body, causing hypoxemia. Very common causes is if there is something filled in the alveolus. That is why the oxygen is not able to enter. This could be because of a collapse. This could be because of severe ARDS, pulmonary edema, so on and so forth, where the perfusion might be normal, but ventilation is severely hampered. So this is called a shunt, and this is a pulmonary shunting. You also have cardiac shunting where you have, like a patent foramen novel, ASDs, VSDs. That's a different kind of shunt. Second principle you should understand is the concept of dead space. Dead space is what? Ventilation is happening, but what you see over here, the perfusion is affected. A very common cause that happens over here, a very common cause of this would be pulmonary embolism, where there is a clot in your pulmonary circulation, and that's one important cause of hypoxemia. There could be an increased ventilation, like an increased tidal volume, breath stacking, autopeep. These are also causes of dead space. You also have you also have apparatus dead space. If you put like too many connections, that will also add to your apparatus dead space, but that's different from what I'm talking here. This is more of a physiological dead space that I'm talking. So these are two important things. A change in the ventilation or a change in the perfusion, a mismatch this can also hamper your gas exchange and lead to hypoxemia. So why this is important is that over here in dead space ventilation, still if you increase the oxygen, probably your hypoxemia may resolve. But here in a shunt, the more, especially the higher the shunt or the bigger the shunt, how much ever you increase your FiO2, even then probably sometimes until and unless you treat the disease pathology, your FiO2, your PaO2's levels are not going to improve and the patient remains hypoxic. So they can go into what you call as refractory hypoxia. So there are two types of respiratory failure you might have heard your seniors or your doctors discussing at the bedside. One is called a type 1 respiratory failure and type 2 respiratory failure. Type 1 respiratory failure is nothing but a failure of oxygenation of the blood. Okay, so this could be because of low FiO2 or a problem in the lungs per se. So that's causing a failure of oxygen. The oxygen is not able to diffuse through the alveolar capillary membrane. Second is the type 2 respiratory failure, which is a failure of ventilation. So for ventilation is both oxygen entering it and washing out of carbon dioxide, both of which happens along the alveolar capillary membrane. So if there is a failure of ventilation, you basically have a type 2 respiratory failure. So in your ABGs, if you do an ABG, an ideal type 1 respiratory failure patient will only have a low PaO2. Whereas a patient who's unable to ventilate or wash out the carbon dioxide, they will have one of two things. They will have an elevated PaCO2, that is a partial pressure of carbon dioxide or hypercarbia will be there. The oxygen levels may be normal or it could be low depending on how severe the PaCO2 is. For those of you who don't know, the normal PaCO2 levels range between 35 to 45. We normally take an approximate value of 40. So depending on the type of respiratory failure, also you may have to change your management. That's why I'm introducing this slide over here. Now, no talk on hypoxemia will be complete without talking about the important things that you do at the bedside. So this is, of course, if you suspect or you want to diagnose hypoxemia, you will always use a pulse oximeter. And during COVID, the sales of this, you all know, have just skyrocketed. So why did it skyrocket? Because this is the fastest, most non-invasive way to assess the patient's oxygenation and diagnose hypoxia. It's in fact considered your 5th vital sign. You know, you do your heart rate, BP measurement, everything, and you put your pulse ox. You do this day in and day out when you receive a patient in the ICU. Okay, and what is very important is that this pulse oximeter picks up the saturation or the oxygen that is bound to the hemoglobin. So the saturation that you see on your pulse ox, it's telling you how much the HB or hemoglobin is saturated with oxygen. Okay, and the target range you all know is around 90. Anything above 94% is usually good enough for your patients. Sometimes if your patient has COPD, we usually keep a slightly lower target of around 88 to 92%, but this is not only for COPD, maybe even sometimes for ILD patients, you target a slightly lower value because that's what their body is used to. Now, what's very important for you to see is what you're seeing over here is something called as the oxygen dissociation curve, where what you have on the x-axis is the partial pressure of oxygen and what you have on the y-axis is the saturation. So this, if you remember, this is a sigmoid curve or an S-shaped curve. So what I want to highlight over here is that if you see over here at the level of 60, that means when the partial pressure of oxygen is 60, after that, this curve sort of just plateaus. So even once the saturation drops from 100 to 90, there's hardly any change in this curve. But after 90, you'll see a steep fall in your PaO2. So the advantage of this is that if your pulse ox shows you that the saturation is above 90, even without doing an ABG, you can comfortably say that my patient's PaO2 is above 60. Because if you see here, against a saturation 90, this corresponds to a PaO2 of 60. So even without an ABG, you'll be able to pick this up. So above a saturation above 90, you should be fine saying that my patient is not that severely hypoxemic. But is it without any limitations? No. There are a lot of limitations that comes with doing a pulse ox, which you should be aware of. First thing first is if your pulse ox is not a correct type of pulse ox, it's broken, you're not going to pick up anything. You know, patients with nail polish, sometimes you will not be able to pick it up. So it's wise to always remove the nail polish and then use your pulse ox. Okay, any sort of movement artifacts, if your patient is shivering, so the patient's finger should be absolutely still within that pulse ox. Even if there's slight amount of movement artifacts or some other interferences from nearby devices, you may not get a correct waveform and a correct reading. This is an important point to note for you all. Okay, then very, very important to note is that this basically picks up the hemoglobin in the capillaries in between that probe. So if there is a decreased cardiac output, if there's increased capillary refill time, if there's not enough blood flowing, if there's any hypovolemia, hypotension, it will not pick it up. Plus, the peripheries will be very cold. When there are cold peripheries, this is another common cause why you're not able to pick up your pulse oximeter reading. Again, changes in hemoglobin. The hemoglobin should be normal. If it's an altered or abnormal type of hemoglobin, you may get false normal or false high values. Like in methemoglobin, you will get a fixed value of 85%. So that should usually give you a clue. If the patient is hypoxemic and your saturations are stuck at 85%, you should think that probably the patient might be having methemoglobin in their bloodstream. Okay, then any other problems like arrhythmias, AF, application of a BP cuff. So normally suddenly you see the saturation is dropping, but what is the main cause? The BP cuff in that same hand is inflating. So all of these are small limitations you see of pulse oximetry or problems that you can encounter which will give you false or spurious readings. So this is just to show you what a normal waveform. It looks very similar to an arterial waveform with a dicrotic notch if the perfusion of the patient is very good. The advantage of the pulse oximeter, it gives you two things. It gives you the heart rate as well as it gives you the saturation of the patient. And it also gives you an indication that the perfusion of the peripheries or the extremities where you put the pulse oximeter is good. If you see a low perfusion, you will see the sort of like flattened out waveform. Maybe you might get a number next to it, but that number might not reflect the actual SpO2 of the patient. If there are noise artifacts, you'll see this clearly on the screen, and the value that comes with it may not be correct again. Are there any other limitations of using a pulse oximeter? Yes, it will not tell you if your patient is hyperoxic. Remember, I told you after 90%, it's a flat line. So the PaO2 can be 60 or the PaO2 can be 200 or 400. It will not indicate or tell you that the patient is hyperoxic. And hyperoxemia is as bad a condition as hypoxemia. Maybe not as bad, but it is also a serious condition. It should not be ignored. Hypercapnia cannot be picked up. Now, if your patient has type 2 respiratory failure, a ventilation problem, you're having a patient who's now, you've given some fentanyl and now they become drowsy, they're not breathing as much. Saturation reading will be absolutely fine. But if you do an ABG, the PaCO2 will be actually rising. So you will be falsely under the impression that my patient is actually stable. So if you have to pick up hypercapnia, you have to have a strong suspicion and then follow it up with an ABG. This may be normal in anemia. You may get a normal value if the patient is anemic, mildly anemic, but the tissues may be actually hypoxemic. So the patient may not show hypoxemia, but there will be actually hypoxia. And because this is giving you an idea of the oxygen bound to the hemoglobin, you don't get an idea of the PaO2. So the PaO2, like I told you, it can be 60 up to 400. You won't know at what level. And only when the PaO2 drops below 60 is when your saturation is going to drop and it's going to start beeping and give you an idea that the patient is becoming hypoxic. By then, it might be too late, actually. Another thing that we all do routinely in the ICUs are your ABGs. You do it for multiple reasons, but this is one of the best measures to identify the oxygenation status for your patient. So from this, you can get a direct measure of your oxygenation. This gives you directly the PaO2, that is the dissolved oxygen, as well as the saturation of the arterial blood as well, provided you're taking an arterial blood sample, Okay, it also gives you, like I told you, something that the pulse ox doesn't give, the information about PaCO2. So you can pick up type 2 respiratory failure and ventilation defects also along with this. You can also grade the hypoxemia, because over here in a pulse oximeter, unless it falls less than 90, you're really not going to know how severe your hypoxemia is. That's not the case with an ABG. You also get other information like acid-base disturbance, so on and so forth. So how do you grade your hypoxemia using a PaO2? So what is normal is considered as above 80 millimeters of mercury. If it's between 60 to 80, you say it's mild, your patient is mildly hypoxemic, 40 to 60 moderate, and less than 50 severe. But at this point of time, I want to tell you one important thing, that do not interpret this PaO2 without knowing what FiO2 or fraction of inspired oxygen your patient is having. Why this is important now? If this patient is on room air, in this ABG, it shows a PaO2 of 83. All is well, you're happy, because over here it says this is normal. But if the same patient was showing a PaO2 of 83 with an FiO2 of 100, no, now you are worried, because now it gives you an indication that probably my patient is severely hypoxemic or in refractory hypoxemia. So you should always know the corresponding FiO2. So on the ventilator or on an NIV, HFNC, it's very easy to know the FiO2. Some of you may ask, what if my patient is on an oxygen mask? So there are approximate values you can gain. And this is the table that shows you that. Like, for example, if your patient is on a nasal cannula, if they're on 1 liter, then it starts with 24. And for every liter above that, just add 4. For 2 liters of oxygen on the nasal cannula, it will be 28. For 3 liters, 20, 32, so on and so forth. So the maximum you can give is around 40, not more than 40 to 44% with the nasal cannula. So this is the limitation of a nasal cannula. Simple face mask, this is a very wide range. It can go up from 35 to 60 liters, even if you crank up your oxygen to around 10 to 15 liters, because there's a lot of entrainment of room air that can happen, rebreathing that can happen with a face mask. Non-rebreathers, whether they're partial or complete or total non-rebreathers, they have slight advantage compared to a normal Hudson face mask. They can go up to 60 to 90, but here also it's a very variable percentage. If it's at 6 liters, you can see it's approximately 6 into 10, that's around 60%, and 10 maximum, it will go up to 90%. With a Venturi mask, depending on the color or the type of the Venturi adapter that you're using, there are particular FiO2s for each adapter, because these are fixed flow and fixed performance devices. Another important thing which might be a new concept for you, but your doctors routinely might be doing it, are something called as a PaO2 by FiO2 ratio. Now, PaO2 you're getting on your ABG, FiO2 you know what you've set on the ventilator. Now, this PF ratios or PaO2 FiO2 ratio we clinicians commonly use in terms of ARDS. So this was ideally, first described as a way of grading acute lung injury or ARDS, but you can use it also to grade the severity of hypoxemia. So if PaO2, which you get on the ABG, you divide it by FiO2, and the FiO2 should be a decimal. Like if the patient is on 90%, you don't write 90, you write it as 0.9. If they are on 100%, by 1. So if the PF ratios range between 200 to 300, then you will be like, okay, the patient is not that severely hypoxemic. But if this PF ratio start decreasing less than 150 and especially less than 100, so this is an indication for, that, just normal oxygen might not suffice. You may have to intubate the patient. If your patient is already intubated and PF ratios are low, you may have to think of other maneuvers. You may have to prone the patient, put them on ECMO, so on and so forth. So we use this routinely. So I just wanted to introduce this concept to you if you don't know it already. The importance of doing the PaO to FiO2 ratios. It's commonly done in ARDS patients, but it can be used in non-ARDS conditions also to grade the severity of the hypoxemia. SpO2 by FiO2 is another alternate that has been used because this is easier to calculate. So I'll just very briefly go through this concept of alveolar arterial gradient. It might be new to a lot of you, but it's an important concept. It's a good to know thing, if not a must know thing for you as a nurse. Okay. So alveolar arterial gradient is nothing but, I showed you the alveolus and I showed you the oxygen that is picked up from the ABG, that is the arterial sample. The difference between what you see in the alveolus and the difference in what you see in the arterial, this difference is normally between 5 to 25 millimeters of mercury. An increase in this tells you that there could be a problem somewhere in the lung or there could be a problem somewhere in the cardiac output. Okay, so this increased A gradient should also give you a clue to the type of hypoxemia. So how do you get this alveolar? How do I know what is the alveolar oxygen? There is a formula for that called the alveolar gas equation. It is given by this formula, fraction of oxygen into barometric minus water vapor pressure minus partial pressure of carbon dioxide by respiratory quotient. Okay, so barometric pressure at sea level is 760. If you're living above sea level, it might be lesser. If you're living below sea level, it might be higher. Okay, so where I am from in Bangalore, we take it as around 687. So in a normally breathing patient, if I have to substitute these values, what is the normal alveolar oxygen? Now, if I'm breathing 0.21 and the barometric pressure is 760, what is this 47? 47 is nothing but the water vapor pressure in the nose or the nasopharynx, okay? Minus 40. So I told you the range is 35 to 40 for PaCO2 divided by 0.8. This is nothing but the respiratory quotient, which is nothing but the oxygen consumed by delivered. And this, if you actually substitute the values, you will get in a normal breathing patient is around 99.8. That means your alveoli contain around 100 millimeters of mercury. Whereas, what did I tell you was a normal value for PaO2? It should be above 80. So if you see, if you subtract 100 minus 80, so this range is normally around anywhere between 5 to 25, and it increases slightly with age. So it's very important is that if this gradient increases, means there is some underlying pathology right from your lungs all the way to your circulation, which you'll obviously have to find out with your clinical examination and tests. But this can give you an important clue. And an important thing to note is that when the patient is hypoventilating, that means high PCO2, this might remain normal. This alveolar arterial gradient is normal. So if your A gradient is normal, one common cause that you can aramse exclude is that the patient is not hypoventilating. You will have to look for some other causes. Some other additional aids that you all can use at the bedside to diagnose the etiology of why your patient may be hypoxic or respiratory failure. One is end-tidal carbon dioxide. So many of your patients, you may not be able to do ABGs all the time to see the PaCO2 values. I told you, right, the pulse ox has a limitation. So, but if your patient has an EtCO2 and the correlation between EtCO2 and PaCO2, if the circulation is normal, is quite good usually. So this can give you an idea if your patient is hypoventilating, hyperventilating. It can also be less if the patient has a circulation defect like hypotension. There also the EtCO2 may drop. But this, if you see the trends of EtCO2, it can give you an idea of whether your patient is hypo or hyperventilating. ECG is important, especially if you have a cardiovascular cause of hypoxemia. Now, arrhythmias can cause hypoxemia, a myocardial ischemia can cause hypoxemia. This without your ECG monitoring, either your 12-lead ECGs or the ECGs on the monitor. This can also give you a clue or a clincher as to why your patient could be hypoxemic and what you need to tackle at that point of time. Another thing I would like to point at this point is that if your patient is hypoxemic from any cause, that itself can be a cause of arrhythmia. So in a hypoxic patient, along with your pulse ox and your ABG and other things that you want, always also keep an ECG monitor on for these patients because they can develop bradycardia, tachyarrhythmias, and all sorts of arrhythmias which you have to pick up and treat The idea is to treat the cause, only then the arrhythmia will subside. But vice versa can also happen. And arrhythmia can also cause hypoxemia. So now, after talking to you so much about the pathophysiology, I'll just talk to you briefly about the clinical approach. What do you need to do when you see actually when saturation is low? First things first, before you go to tackle this patient, the main thing is don't leave them hypoxic till you troubleshoot. The main thing you have to do is keep the patient on 100% oxygen, or increase if you are on an oxygen face mask, probably you crank it up, go up to 15 liters. If you can put the patient on a high flow cannula or NIV, which can probably give you a higher FiO2, increase to that. So before you troubleshoot, first thing, make sure you're giving adequate supplemental oxygen. Sometimes the patient might just crash and you have to intubate the patient also before or while you simultaneously troubleshoot for the cause of hypoxemia. Another thing you should see is how does your patient appear. If the saturation is showing 62, but your patient is aram-se eating and comfortably sitting and talking to his family, then just check if the pulse oximeter is faulty. Sometimes you may have to put it on yourself. So just look for any spurious causes or whether there are any faulty mechanisms as to why there is so much of a discrepancy. But if your patient is in respiratory distress, obviously you have to act fast. So when I say act fast, I would start with don't forget the airway breathing circulation. I think this comes to any healthcare professional with any emergency. So particularly to hypoxemic patients, what you should look for in the airway is if your patient is not intubated, you should see if your patient can talk. If your patient is able to talk, the one thing you can say for sure, like talk clearly, with a normal voice, you can say for sure that the airway is patent. But if the patient has some hoarseness or is not able to complete sentences or has a high-pitched sound, which you call a stridor, you should think that something is wrong with the upper airways. Now, stridor is a high-pitched inspiratory sound, okay? So this could be seen in any upper airway obstruction, laryngeal pathologies, angioedema, inhalational injuries. So as a smart nurse, what you should do is not only alert your doctor, put oxygen, but you may also have to prepare your difficult airway card, because should this patient require intubation, probably this might be a potential difficult airway as well. Breathing, of course. Now breathing, whatever oxygen is going to the lungs, is the chest wall moving correctly? You may have to auscultate the patient. I don't know how many of you are familiar with it, but you may have to auscultate the patient. Use of accessory muscles may tell you that the patient is probably going into respiratory distress, needs some urgent intervention. Circulation, like I told you, hypoxia itself can cause hypotension. Hypotension can also cause hypoxia. So if the patient even has normal lungs, but the cardiac output is low because of a cardiogenic shock and MI, look for these features of hypotension, correct it. You may have to give fluids, vasopressors, but until the BP improves, the oxygen is really not going to pick up. So more often than not, a hypoxic patient will be dyspneic and tachypneic. But this is not the rule, but this is the most common finding. You will see amount of dyspnea and tachypnea. There was a concept of happy hypoxemia in COVID that was there, but that pathophysiology is totally different. I'm talking of other causes of acute hypoxemia over here. Now, as a nurse, especially if it's a patient you are taking care of, you should know what are the symptoms the patient came to you with, because that itself can give you a great clue as to what my patient is hypoxic due to. Also the comorbidities, like if the patient already has some underlying COPD or asthma, that itself can take you down that path that, oh, my patient is probably now having bronchospasm. Or if my patient is a case of MI, probably it's a pulmonary edema. If the patient is a case of CKD, maybe it's fluid overload. So that knowledge of the symptoms and the comorbidities are very important. The patient might have been on domiciliary oxygen or BiPAP. So these patients might already have a low oxygen level to begin with. Then, of course, if there's any recent surgeries, especially abdominothoracic surgeries, so the patient is you're working in a post-op setup, that itself can give you a clue, or maybe my patient is hypoventilating, my patient has pain, I'll have to tackle that, and maybe then his hypoxia will improve. So you should also know what is the diagnosis, what diagnosis your patient came with, because that itself, a worsening of the current problem also might be explaining the cause of hypoxemia. If your patient is absolutely fine and now there's a sudden hypoxemia, then that's an acute cause, and then you have to go around in a stepwise manner to find out what possibly has gone wrong in your patient. So common symptoms these patients with hypoxemia would have is dyspnea, cough with or without sputum production, chest pain, wheezing, hemoptysis. Dyspnea is a common symptom that can be there in cardiac or a respiratory pathology. Cough with sputum production, usually you see it in infective pathology. Chest pain could be in myriad problems. It can be in an infective. Even a patient with pneumonia can have chest pain. A patient with MI can have chest pain. A patient with pulmonary embolism can also have chest pain. So these will all give you clues. You have to basically link it together. A patient with active wheezing. Now, wheezing is basically a high-pitched expiratory sound. It's more of an expiratory sound. And this could be obviously associated with both a bronchial asthma or a COPD problem as well as a cardiac asthma. Hemoptysis, like sudden onset of hemoptysis due to whatever cause, that can also give rise to hypoxemia. Certain signs that you have to look out for on general physical examination. So your normal vitals, obviously these patients would be hooked up to some monitor. They would be tachycardic or tachypneic. They could also be hypotensive. So unless and until, like I said, you don't treat the cause of hypotension, then it's not going to improve. And now what's very important to note is to look for something called as a capillary refill time. So even if the patient's BP is fine, we should look for what you call the capillary refill time. So if you see over here, you have to give some pressure to the nail bed or the tips of the fingers for at least 5 seconds. And once you release the pressure, it should refill within less than the capillaries, or the red color should blush back within 3 seconds. If there is a delay, these are subtle signs that your patient is in clinical shock, and you may have to alert your doctor or act fast. Presence of pallor can indicate the presence of anemia. Don't wait for cyanosis to occur because this is usually a late finding. Where do you look for cyanosis? It could be peripheral, in your fingers, or in the tongue. If it's in the tongue, it's what you call as a central cyanosis. Central cyanosis is a late finding, and it tells you that the patient is severely hypoxemic at this point. Presence of fever could tell you about whether the patient has an infective pathology. Now, why I have highlighted this altered mental status is that a patient who's suddenly fine and now becoming delirious or hypoxemic. Now, there's a saying in the ICU, a patient who is restless should be considered hypoxic unless proven otherwise. So most often than not, if your patient is restless, your base thinking is, oh, maybe I have to increase the sedation or I have to restrain the patient, he's becoming restless. But this is a very, very subtle finding that your patient is becoming hypoxic. If your patient is not suddenly able to lie down flat, this is what you call as orthopnea. They will assume this tripod position or sitting position. That also sort of tells you, these are early signs that tell you that your patient is probably going into some sort of fluid overload or is becoming hypoxemic, which you need to tackle. Excuse me. So how will you tackle it? So most of these patients who are starting to show these signs of hypoxemia, give them a head-up position, what you call as a semi-Fowler's position. I'll show this to you later. Immediately, if you're suspecting any secretions, suction the oral airway, oropharynx. You may have to give a jaw thrust. If they're becoming drowsy, not protecting the airway, you may have to give what you call as a jaw thrust. Any audible stridor, you should be doubly careful. You may have to prepare for intubation, a crash intubation. So this is one of the examples to show you what is accessory muscle use. So the common accessory muscles you'll see using over here are your sternocleidomastoids. You can also see the infraclavicular hollowing. You can also see the tracheal tuck. Sometimes you may see flaring of your ala nixi, intercostal indrawing. All these signs should never be taken lightly. This means that your patient is struggling to breathe and you have to basically probably increase the FiO2, or you may have to increase the support, either NIV or intubate the patients. On physical examination, I know most of you usually by this time would have called the doctor, but there are certain things I would like you also to learn how to do. Go to the foot end of the bed with the chest exposed and watch, is both the chests moving at the same time. If one side is not moving as compared to the other, think of some pathology. Probably there's a large atelectasis, there's a big mucus plug. Maybe you may have turned the patient over to a suction, give some gentle physiotherapy and get that mucus plug out. It could be a dense consolidation on that side. That's why it's not moving. If it's a chronic problem like fibrosis, your patient should not acutely desaturate. But if it's an acute problem like a collapse or consolidation, then one side of the chest will not move as much, depending on which side is involved. If there's an increased fullness, now this is difficult to pick up. This can be a sign of pneumothorax. This is usually better picked up when you auscultate your patient. There might be a paradoxical movement, especially in trauma with flail chests, or you'll see what you call as an abdominothoracic breathing. The abdomen moves out during inspiration, which is not normal. So this all should give you a sign that your patient is developing worsening respiratory distress. Auscultation, I don't know how many of you do it as nurses, but if you do it, or you should, this is some skill that you all should learn, especially because most of you all are critical care nurses, and if you all plan to go abroad, more often than not, you all have to even learn how to auscultate. So some things that you can pick up. Basically, there should be symmetrical breath sounds on both sides. So if one side you're hearing a normal vesicular breath sound, the other side is reduced, there might be a pathology on that side. Look for specific added sounds. Some of the added sounds are that you should learn to recognize are rhonchi. Now, wheeze or audible wheeze is something you can hear, but rhonchi is something that you have to auscultate. It sounds just like a wheeze, a high-pitched in expiratory sound, very commonly seen in any condition causing a bronchospasm, asthma, COPD. Crepitations are fine or coarse, depending on the pathology. Now, if you have bilateral fine crepitations, it's basically like papers rustling, that kind of a noise. If you hear this bilaterally, especially starting from the base and moving upward, this is commonly, telling you the patient might have pulmonary edema. If you have unilateral coarse crepitations, this could give you a clue that the patient might be having or developing a pneumonia, or a worsening of an existing pneumonia might be happening. So what if your patient is intubated, stable so far, and suddenly becoming hypoxemic? So what you should do is, this could be a problem with your patient, or this could be a problem with the equipment that is causing the hypoxemia. So you need to assess the patient all the way from the ventilator to the patient, or the other way around, but it should be in a systematic fashion. So this is a mnemonic to remember. DOPEs. One is displacement. Displacement of what? Commonly the endotracheal tube, if the patient is an EF tube or a tracheostomy tube. Obstruction of these tubes. Now, displacement, when I say, it could be either that the tube has migrated out or the tube has migrated endobronchially. Okay, so if there's an endobronchial movement, it commonly goes to the right side. So if you auscultate the patient, or if you see the patient, there'll be no left-sided chest movement, and you will not hear any air entry if you auscultate these patients. Then, of course, lung pathologies per se, pneumothorax, pulmonary embolism, pulmonary edema, equipment and ventilator patients, and stacked breaths. This is something you see with autopnea. Okay, so these are the causes of hypoxemia in intubation patients. Like I said, it could be equipment related. We've already discussed this. And patient factors, that is cardiogenic edema, aspiration, pneumothorax, so on and so forth. Even large pleural effusions, gross ascites also sometimes can give rise to sudden onset hypoxemia. I know this doesn't suddenly happen, but if over a period of time, if the ascites is that large enough, it can affect the compliance of the lungs, the chest wall, and make your patients hypoxemic. So what can you do at this point in time? First, make sure the tube is in position. This is where your ETCO2, what I pointed out earlier, will help you. Because if it migrates out, then obviously the ETCO2 will suddenly drop. If it goes to in, CO2 will build up. ETCO2 will start building up. It will give you a clue. Very important is if you've just transported the patient, brought them back, suddenly the tube might have slipped out. It's gotten displaced. So your ETCO2 will also help you there. Ensure the patency. So I think this is something that most of you all will do. Hypoxemia and suctions that everyone will do. So this is an important maneuver, yes, but it should not be the only maneuver you should do. You should also look for other causes. If you're not able to figure out the cause and you think the ventilator might be the pathology, if there's some leak or some problem that's happening there, what I'd suggest is ambu your patient, like disconnect from the ventilator and ambu. If with the ambu, the oxygen is picking up, probably something is wrong with the ventilator setup, which you will need to probably figure out. Check the cuff. If there is a cuff leak or the cuff is now not malfunctioning, there's an air leak, that itself can cause hypoxemia. This could be audible. You can check the cuff pressure also with a manometer. This is also required. Hemodynamics of the patient. Sometimes there may be no pathology in the lung or the patient, but the patient is hypotensive. That itself can be a cause of hypoxemia. So if you don't correct that, then your saturation is not going to pick up. And of course, correspond it with check the corresponding waveform of the pulse oximeter. Now, because most of you all are critical care nurses, I also want you all to identify the problem from the ventilator graphics. So what you should check is something called as the peak airway pressures, which I'm sure most of you all are familiar with. So any patients who are on controlled modes of ventilation will have a particular peak airway pressure. You have to set your alarms correctly, first of all, to identify if it is increased. So if your peak airway pressure can increase in two conditions. One is if there's an increased resistance or a decrease in the patient's compliance. Resistance means any issue with the tracheobronchial tree. And compliance involves something to do with the chest wall or the alveolar pathologies or lung pathologies per se. Okay, so increased resistance, commonly what you will see is an increase in the peak airway pressure, but your plateau pressures are normal. I don't know how many of you all know to check the plateau pressures. So on your ventilators, go look for the inspiratory hold and just press it for 3 to 5 seconds. So once you press this and the patient is on a controlled mode, you will get this P-plat reading additionally. So P-plat tells you about the compliance of your lungs. So if the compliance is normal, that means there's no pathology in the lungs or the parenchyma, this P-plat stays normal, but the peak pressures will go up. Okay, so this will be seen normally with increased resistance like a blocked tube, bronchospasm, mucus plugging, exacerbation of COPD. If there's a problem with compliance, both things will go up. The peak pressure will also go up and the P-plat will also go up. Usually we target a plateau pressure of around 30 centimeters of water, which is given by the ARDS guidelines, ARDS net guidelines. So if it crosses 30, so that should automatically warn you that there's a major problem happening with the compliance. So if you see the ventilator beeping, increased peak airway pressure, don't just assume that, I'm going to suction and things will get better. It's just a block. You have to first check the P-plat. If the P-plat is also high, it's probably a compliance issue, and it may have to be tackled along with your suctioning and other, looking out for other obstructive causes as well. This pulmonary pathology could be anything: pneumothorax, pneumonia, atelectasis, pulmonary edema, so on and so forth. So simple measures you all can do as nurses at the bedside. One is obviously if there's a hypoxemia, raise the head end of the bed. This is what I was saying, the semi-fowler's position, at least 45 degrees. And this is not just for an acutely hypoxemic patient. For any patients who are admitted to you with sort of a respiratory pathology or a cardiorespiratory failure, encourage them as a part of you as a nurse or as a respiratory therapist or a physiotherapist. All of you all should encourage your patients to do deep breathing exercises, incentive spirometry. I cannot stress on how important this is, especially if your patient has a chest wall pathology, lung pathology, or an abdominal wall pathology like glossositis, so on and so forth. Especially if they're post-operative patients, post-laparotomy or post-thoracotomy patients, incentive spirometry should not even start at post-op. It should start well pre-op itself. Make your patient do an incentive spirometer. Don't just buy it and keep it at the bedside. Make sure they do it every 2 to 4 hours. And it is your job as a nurse to encourage this. This will help to open up the atelectatic portions and prevent any further pneumonias, because once the lungs are open, the tendency of the collapse, stasis of secretions are much less. So as much as I can stress on, this is a very, very important way to help open the atelectatic alveoli and prevent infections. Use of bronchodilator. So if you're hearing audible wheeze, I know most of the time your doctors would have written, give Astelin, SOS. So when to give, what is this SOS, you have to use your clinical judgment. So if your patient is having some audible wheeze, go ahead and give bronchodilators along with alerting your doctors. Appropriate use of suctioning. Don't do suctioning all the time just because the patient is hypoxemic. It might be some other cause. But yes, suctioning to a great extent will help to prevent any mucus plugging if done appropriate intervals of around 2 to 4 hours. But don't do it frequently. It can cause trauma. A very, very important point I want to stress on is many a times the patient might be tachypneic, tachycardic just because of pain and anxiety. So just alleviating this pain and anxiety will go a great deal of way to avoid any further hypoxic complications. So as nurses, what I want to give you is some some points that you all should not miss. Or these are points that are often missed: leaks and disconnections. So what you see over here is you've cranked up your oxygen, but it's not increasing. That's because the oxygen tubing is disconnected, especially post a transport. Sometimes there might be some disconnection that would have happened. You should look out for that. That could be a simple cause that you can tackle at the bedside. HME filters often get clogged and blocked. Also, if one of the scabs are loose, then that also can give rise to leaks, something that's very difficult to pick up until you have an eye for it. Next thing is, if your patient has an ICD or a pigtail and you have clamped it and the patient is spontaneously breathing, the pneumothorax or the patient suddenly will have a full-blown pneumothorax with subacute emphysema. So make sure if the patient has an ICD or a pigtail that's connected to an underwater seal, make sure air column movement is always there. Do not please keep it clamped for a long period of time. I know if you will have to transport, you'll sometimes clamp and take the patients, but that's not usually advised. It has to be kept open and kept below the patient even during transport. Lastly is the cumulative fluid balance, because you all as nurses maintain the input and output chart. So this is very, very important. Sometimes you'll be pumping the fluid with the patient with 100 to 150 ml of fluid. The patient might be oliguric. There might be increasing cumulative fluid balance. This itself can push the patient to fluid overload and be a significant cause of hypoxemia, especially in CKD patients or patients who have known reduced ejection fraction. As nurses, I don't want you all to wait for the patient to go into a crash situation. Watch for the warning signs. If your patient was on 2 liters at the beginning of your shift and now gone up to 8 liters or 10 liters, this is not something you should take lightly. You should inform the doctor or your senior nurse that something is not right and my patient is requiring more oxygen. You figure out what the pathology is. Always interpret the PaO2 with the ongoing FiO2. So if the PaO2 is 83, but the patient was initially on room air and now 83 with 2 liters, with 5 to 6 liters. Now, this is the example I had asked you to ponder about. So if the FiO2 is going up, but the saturation is normal, don't be satisfied. It means that the oxygen requirement for your patient is going up due to some pathophysiology, which you have to identify. the accessory muscle uses. It starts very subtly, some sort of like tracheal tugging, sternocleidomastoid, ala nasi flaring. All these are very subtle signs that you should pick up. The patient slowly becoming tachypneic or hypoventilating, then causing a change in mental status. So if the patient is slightly becoming delirious, don't just assume it's because of sedation or lack of sedation. Many times we often miss the diagnosis of hypoxemia. And I've talked a lot about hypoxemia, but don't forget the concept of hyperoxemia. So nowadays we are moving to this concept of less is more. You really don't need 100% saturation in everybody. In a critically ill patient, usually above 94% is more than enough. In fact, even ARDS patients, the target saturation is 88 to 92. Nobody wants you to achieve a 99% saturation because that is not actually found to improve the mortality of your patients. So there are certain exceptions to this rule, one of them being pregnant patients, one of them being patients with traumatic brain injuries. But otherwise, more often than not, anything above 94% or even 92% is usually well and good for your patients. Hyperoxemia can cause oxygen-induced free radical injury. It can cause collapse of the patient, atelectasis of the patient. These are things that are difficult to pick up. So adjust the FiO2. So most of you'll intubate the patient, keep 100% FiO2, go and start documenting or go away for some other work. Bring it down to maintain a saturation limit, like ask your doctors, or at least a target above 94 should be safe enough for your patient. Keep the least amount of FiO2 to maintain a target saturation of above 94%. So I think with this, I'd like to end, and just a few clinical case scenarios I would like to ask if Dr. Mahima would like to discuss this with the...
Yes, sure, we can discuss.
Yeah, okay. So I would like, first of all, just to give you a case scenario, a common scenario you would have seen in your hospital. So you have a 75-year-old male patient. He has no comorbidities. 4 days back, they were operated for right femur fracture and they were in the ward. Now, suddenly they have developed breathlessness, chest pain in the ward, and they have come to you. The patient has been brought to you now because of this breathlessness and chest pain. So your patient is conscious talking, but is tachycardic, heart rate of 140 per minute, sinus, BP of around 100 by 60, not on any vasopressors at present. Saturation is 86% on 2 liters. And the respiratory rate is 36 per minute, sorry. So what, as a nurse, would you think first? What is probably going wrong? So I think it's very obvious that your patient is hypoxemic because you can see that the pulse ox is showing 86%. But what would you like to think? What is your differential diagnosis? Maybe you could answer in your chat box, or if anyone wants to unmute and speak, that's also fine. You can write in the chat box, whatever you will feel. Okay, great. I got an answer of pulmonary edema. All right, fine. Anybody else? Any other? Make a guess. Emboli. Great. Thank you. Tamil, Mati. One more. Any other answer? Okay. So the approach so far, fluid overload. Okay, thank you. That's great. So good. I'm glad you all are thinking. So now your patient is, think of the clinical scenario. He's a post-op patient, elderly post-op patient. So because of the fracture, probably they are immobilized and they've come with breathlessness. Now the clue here is one thing is sudden onset and next thing is chest pain. So one possible thing I would think of would be, yes, pulmonary embolism is a very good differential diagnosis at this point of time, especially because of recent surgery, immobilization. Another thing could be an ischemic event itself. It could be an ACS that the patient is having. That itself can cause hypoxemia. Next thing, like some of you said, fluid overload, that's also a possibility, but the fluid overload usually less likely to cause a sudden onset breathlessness, especially if a patient has a normal cardiac function. But this is an elderly patient, might have diastolic dysfunction. So yes, it is definitely possible because you don't know what is the intake output of the patient. So how would you like to go ahead? Do you want any particular tests at this point of time? What would you like to do after this point of time? You can again type in the chat. I'll have a look. Do you want an ABG? Do you want to auscultate the patient? Do you want to just call the doctor? What do you want to do? I mean, you have to like find out, right? What's the problem? Some of you said fluid overload. Okay, chest X-ray. All right. ABG, great. Okay. Is there anything else? ABG, okay. Auscultation. Okay. So now when I auscultate the patient, It's clear breath sounds are there, slightly reduced at the bases, and my chest X-ray is normal. Okay, so what would you like to think at this point of time? ABG was done. ABG is only showing severe hypoxemia. So the PaO2 with this 2 liters of oxygen, now I've increased it to 10 liters. PaO2 is showing 55 millimeters of mercury. PaCO2 is normal at around 36 millimeters of mercury. So what do you all think right now? So some of you said fluid overload. Do you want to still stick to it, or you want to ask for something else? Does anybody want to do an ECG? Does anyone want to do an echo? CT chest, great, okay. Yes, somebody said yes, they want to do an echo, yes. So an echo, I know it's not something that nurses would probably ask for, but it would be a part in the sort of like workup towards the patient, because this will tell you. But as a nurse, I think the basic minimum you could ask for this patient would be an ECG. You can pick up any, sort of a myocardial infarction, any sort of, STT changes that are there in your patients. That could explain. And also you can pick up certain ECG findings of pulmonary embolism. The most common being sinus tachycardia, yes, but you may pick up an S1, Q3, T3 pattern. So that can also help you come to a diagnosis. CTPA, like somebody said, CT chest, yes, that would also be a right way. You would probably ask your doctor, suggest it to your doctor or your treating physician that probably the patient might be having a pulmonary embolism. So that will be a great way to go ahead. So you can use ABG, you can use clinical examination, chest X-ray, and further tests. Now, further advanced tests, which are good to think about and get done, which will help you to come to your diagnosis faster, like you all said, echo, CTPA, so on and so forth. So this patient ended up having a pulmonary embolism and required therapeutic anticoagulation. Okay, so I'm glad that you're all thinking in the right path. Coming to the next one. Okay, this is a relatively easy one. So there's a young patient who was diagnosed as viral pneumonia with ARDS and admitted in your ICU. You have put them on, okay, don't worry about PRBC, you have put them on volume control mode basically, with a tidal volume of 410 milliliters, RR of 28, FiO2 of 0.8 to begin with when the patient came from EMED, and PEEP was 10 centimeters. You're gradually bringing down the FiO2 and you come down to almost 0.54 hours later. But after half an hour, you see that the patient is desaturating, and the ventilator now is saying that the peak pressure is increased. The peak pressure, which was 20, has now become 36. So what would you like to do first? What do you want to do? Suction, okay. I guess that would come as one answer. Suctioning, okay. Anything else? Tube bite. Your patient is actually paralyzed. So there's no question of tube bite. You're suctioning, nothing really is coming. There's no secretions. Any leak? Okay. You want to look for a leak, all right. So remember what I said, you go from the patient end to the ventilator end, or the ventilator end to the patient end, okay? So I know most of you all, this thing first knee-jerk reaction is to do a suction. Yes, look for any disconnections, that's a good thing, but the disconnection will not cause a increased peak pressure. So block of HME filter, yes, somebody is thinking on the right track. So look for what is the problem. Is the problem in this patient a problem of resistance or decreased compliance? Is there an increased resistance or decreased compliance? So remember what I said. First thing first to know that is you might have to check the plateau pressures as well. Now, if this patient's plateau pressures are also up, then you will probably think of there's probably a compliance issue. Okay, so this patient could have developed a pneumothorax. Now, this patient is an ARDS. There's a definite chance of barotrauma or polytrauma or some silly. So yes, you should, yes, some of you are saying that you will want to suction, check your ventilator tubings, increase peak pressures, give prone position, correct. But it should be in a systematic fashion. First, figure out if it's a resistance problem. Only then will suctioning and other things help you in your patient. If it's not a resistance problem, it's a compliance problem, you will have to deal with it. Because if there's a pneumothorax, you'd rather want to auscultate the patient, get an X-ray for your patient. Probably the patient has developed a pneumothorax. If you auscultate, there might be less air entry. You might require an ICD as well. And if the hypoxemia is still refractory, it could be worsening pulmonary edema or worsening ARDS that's causing the problem. So yes, then in that condition, yes, probably you will have to prone the patient. If it's purely a resistive problem, you will only have an increased P peak, but your P plateau levels might be normal. In that case, you will have to figure out, is the problem in the ventilator tubings? Is there any blocking? There is a mucus plug somewhere that has to be suctioned out. that's when your suction, giving bronchodilators probably would help. So X-ray chest is a great way to go forward, yes. So first you will examine the patient from the ventilator end to patient end, look for any, if it's a resistance problem or a compliance problem, and then proceed accordingly. Getting a chest X-ray is a great idea. You may also have to do an ABG also. That will also give you some sort of a clue. Because if there was no CO2 rise and now there's a CO2 rise, maybe it's an endobronchial intubation, maybe it's a pneumothorax cells developing. So these are additional tests that you can do that can give you a clue. So I think with this, I'd like to end. Thank you all for a patient listening. Over to you, ma'am. Any questions, any doubts?
Yeah. Any questions from anyone?
You all can type in the chat box. Not able to hear anything.
And I think we simplified.
Ma'am, there is no question. Only one question is there. Hello, Dr. Carol D'silva. That one question is there: suction and check venti tube and increase peak pressure and give prone position.
That was the answer that was given by someone. They were giving the answer. So there is no question in the chat.
So, no, there is not no any questions. So we can end the session.
Yeah, thank you so much, Dr. Carol. It was a very well prepared topic, and I think you explained it very nicely and made it very simplified. Thank you so much.
Thank you, ma'am.
Thank you all. Thank you.